There's been a lot of controversy about PSA, and when patients come to the office, we find it to be a fundamental piece of information that is quite useful. During the PSA era, which began in 1989 officially, the mortality rate for prostate cancers decreased by about 30%. We're trying to understand two things. Can we detect disease early? And if we do, does it benefit the individual? Our position is that PSA screening saves lives. There would be really no point in doing screening if after early detection you couldn't do something about it that was meaningful. Well, if you look at the date at the bottom of this, on May 5th, what this deals with is the randomized study for prostate cancer detection in Sweden. And this group of people were divided into a group that we call active surveillance versus treatment. Here are the statistics. Evidence that disease spread, which we call metastasis, was significantly diminished. Prostate cancer deaths diminished, and all causes for death amongst the screening group were diminished. First, in the European randomized study, the benefit was that 40% fewer diagnosed prostate cancers had advanced disease at the time of diagnosis, and 20% had a lower prostate cancer death rate. The other thing that was noticed, that the people that benefited most tend to be the younger people in the trial group. One of the problems that surfaced was that the number that you needed to treat was fairly high. Other studies didn't have this high number, so we started to look at it. And what we determined was that the state of health of the individual, the age at the time the study was being done, and the length of follow-up were critical to understanding how efficient this system was in determining who needed to be treated. Well, in this graph, this is the control group, and this is the adverse outcome. This is the screening group, and this divergence suggests that this group had fewer problems at a given point in time than the control group. The second study group is the American study. This study came to the conclusion that there was really no difference and no value in the screening. This is another analysis of this very same study, taking into consideration, took out the illness and the aging factors from these data, and then looked at its value. Well, it was amazing. There was a 44% difference between the controls and the screen group. And not only that, the number needed to treat dropped from 48 to 5, which is dramatic. This third trial is from Göteborg, Sweden, and it's a population-based trial. And what that means is that all comers were not taken, and it focused on a particular age group from 50 to 64. And when you looked at all of these things with this trial, once again we see a significant benefit at the time of diagnosis of not having advanced disease. In other words, there's benefit to being diagnosed early, assuming you have health in other systems and they don't cloud the interpretation of the outcome. Here again, there was over a 40% difference in mortality, with the screening group being the benefactor and the mortality of the control group being significantly more adverse. The number needed to treat in this particular study was 12, and I reference the breast cancer trials. The number needed to treat is 10, but the bottom line is that patients who were detected early and treated early had a better outcome in the context of not being made ill or worse by prostate cancer. The surveillance, epidemiology, and end results are essentially data that's taken from the Medicare payment database. This demonstrates that there's a 75% decrease in metastatic disease presence at the time of diagnosis. Today, when we see people who do have the diagnosis of cancer, we're thinking cure. At the time when I began my practice, we were thinking, how do we make these people comfortable, because we can't do anything about the problem. And there's no question in my mind that PSA has a big hand in that. In 1992, the mortality rate was 39.2 per 100,000. And the number of prostate deaths then, as you can see, were 51,000 plus. In 2007, the number of American males was close to 150 million. And the prostate cancer death rate was significantly lower, 36,000 versus 51,000. Let's make the assumption that the prostate cancer mortality rate didn't decrease. If the age-adjusted mortality rate had remained the same, there would have been close to 60,000 prostate cancer deaths. But instead, there were only 35. Thus, there were 24,000 fewer prostate cancer deaths. So what would that number look like? Well, here we are, March Madness. This is a basketball arena with 24,000 people in attendance. That's the number of lives were prevented from having an adverse outcome because we utilized screening techniques founded on PSA. These are countries that do use prostate cancer screening using PSA. The United States, we can see the mortality rate dropping. Canada, France, Germany, Spain. Here are countries, I'm not saying they don't use prostate cancer screening to some degree. The trend is up. There's no question that we want to have the earliest diagnosis, the smallest volume of prostate cancer to deal with at the time we're considering curative or beneficial treatment options, and we're not looking just at palliation as we did back in the 70s. As I walk through different parts of the country, there are articles about what's wrong with PSA, and it's creating all kinds of problems and an overdiagnosis and morbidity and mortality from treatment, discouraging people from having screening using PSA. These opponents who are vocal and have the attention of the media are truly doing a disservice to the men in our society. The American Urological Association and the American Cancer Society have cautiously taken the stand that PSA screening, prostate cancer screening, is of value. The bottom line is both patients and physicians are being confused by these negative media commentary about the way we try to do early detection for prostate cancer. We want you to be part of the effort. We want you to go away from here with an opinion. If it's a negative opinion, I didn't present it well. If it's a positive opinion, carry the torch. But the bottom line is, if you do so, you will save lives. Might even be your own. I'm going to share a few things with you that I see and what I believe that will will extend beyond Dr. Catalona's perspective. Surgery and radiation therapy are the standard treatments for newly diagnosed prostate cancer. These are aggressive treatments, and they do have some problems associated with them that can decrease the quality of life for some with altered sexual and urinary functions, erectile dysfunction, urinary incontinence. Risk stratification, being able to look at this equation and say, this is a situation that needs treatment right now, and this one really doesn't. We can watch this patient carefully, is what an active surveillance program is all about. Clinicians identify cases that need aggressive treatment, and more importantly, they have time and energy to develop new therapeutic strategies that may not have those complex situations associated with them. That sounds futuristic, right? Well, it's already here. This is the cryo system that we use for treatment of prostate cancer, and it's very adaptable to focal therapy. HIFU, high intensity focused ultrasound. It does the same thing with heat that we're doing with cold with cryo. Here's how it works. This probe not only images but generates a high ultrasound energy that can be focused at a different level within the prostate by computer direction. When we know there's a specific lesion, we can treat a segment of the prostate, a portion of the prostate. So we have the capacity to do focal therapy with HIFU. The point is, we don't have to wait for tomorrow. Tomorrow is here. PSA screening saves lives. It gives men more time to be with their families and smell the roses. Thank you.